All right, everybody. So the last 5 minutes. Sorry, I couldn't squeeze it into the other video, apparently. I ran out of time. All right, so the last point I wanted to make about opioid abusers, right? I talked about we want to treat their pain. We don't want to just assume that they're seeking. These patients are really hard to get comfortable. I've dealt with a lot of opioid abusers in terms of pregnancy, and when they have a C-section, it is nearly impossible to get them comfortable post-op. We do it, but it's really challenging. Most of the patients who are recovering opioid abusers, do you know what they're taking? So for those of you who said methadone, you're right. And a methadone clinic is in most major cities and towns. Waterbury, which is where I practiced in Connecticut, has the largest methadone population. So their population is greater than Bridgeport and greater than Hartford. So it's a really large area of concern when patients are on methadone. So the thing about a patient who's on methadone, they're on that to stay sober. So meaning when they're on the methadone, they don't crave their Oxycontin or whatever it was they were addicted to. That being said, when they're on methadone, it makes it hard to give them other medications in order to help with their pain. Their pain tolerance is very, very low, and it's also hard to get those receptors covered in order to adequately manage their pain. There are a couple of pain medications that would precipitate severe withdrawal symptoms in a patient who was currently abusing opioids. So in a patient that is an opioid abuser, you would never use a pain medication that's an agonist/antagonist. Okay, and chapter 28 describes that, but an agonist-antagonist, and an example of that is Nubain, which is a medication that's an agonist-antagonist, so it works by both agonizing and antagonizing receptors. We would never give to a patient who's an opioid user. All right, so the last special area is pain management at the end of life. And again, here I used the example early on about giving morphine, and if a patient is having signs of morphine toxicity and they're at end of life or hospice care, we're not going to give them that Narcan to reverse the morphine toxicity. We're going to be okay with giving them a comfortable death. Again, this is largely in the hospice setting, but also can be on a med-surg floor if the patient is in hospice care and just hasn't gotten discharged yet, things like that. So it's important to keep in mind. These patients also really benefit from therapeutic touch, from other alternative regimens, as well as the adjuvant medications, which were our tricyclic antidepressants, the amitriptyline, or our anti-seizure medications. All right, so here's a question. You're caring for an older gentleman at the end of life who has been receiving large doses of morphine for several months to control metastatic bone pain. So metastatic bone pain from cancer. You notice that his respirations have slowed, but he's still moaning in pain. He has an order for MS, which is morphine sulfate, 10 milligrams, sublingual PRN every 2 hours. His last dose of morphine sulfate, that's MS, was 6 hours ago. What do you do? So the second answer, right? Administer the morphine sulfate knowing that this may hasten his death. He's not at the end of life. This is not something that we're going to give Narcan to reverse. We're not going to wait for his respirations to improve, nor are we going to necessarily contact the prescriber. In this case, we want to keep him comfortable. This is just a description from chapter 28 to give you some examples of the names of medication, okay, that we're talking about when we talk about medications. Don't worry so much about the receptor types. I just want you to be familiar with the names, especially morphine and codeine and Narcan we had talked about as well. All right, so just a quick review here for you, and I know you have this printed out, so just some helpful hints as you prepare, and I want to thank you guys all for listening. My husband and I will be crazy moving with the baby as you listen to this, so thanks for being flexible and for listening to the material, and I will see you all on Monday at 3:30. Perfect. Have a good one, and email me with any questions. Thanks, guys.